Pieter J. I'm a consultant urological surgeon. I work at Epsom and St Helier and also at St George's, and I do my private practice here. And I've been a consultant in the UK for about 12 or 13 years now. So what, just in very basic terms, what exactly is cancer? Obviously there's lots of different cancers, they're not all the same, but in very broad terms it's uncontrolled cell growth. A cell or cells become highly abnormal with high rates of cell division, and this growth does not obey the natural constraints and barriers of cell growth. Cancer cells, unlike normal cells that are growing or dividing, cancer cells can invade adjacent structures, it can cross natural barriers, it can spread to sites away from the primary tumor, and it can acquire a blood supply there. It's important to remember that cancer is named after the cell or the organ where it originated from. So if somebody, let's say, had kidney cancer that spread to their lungs, then we don't call that lung cancer, we call that metastatic kidney cancer. Cancer retains the name of the origin, the site of origin. So how does it start? In the kidney, it's usually a single cell or cells that become abnormal. And in a solid organ, such as the kidney, unlike perhaps the hematological, the blood system cancers, these cells will grow and divide and eventually form a small mass, a tumor. And this tumor can then continue to grow, acquire a new blood supply, and can grow through the barriers around, let's say, the kidney. It can grow into the lymphatic system and spread that way to the lymph glands that are all throughout the body, around the arteries, and it can spread via the bloodstream. It can grow into blood vessels, and kidney cancer specifically has the propensity for growing into the veins of the kidney. The blood from the kidney drains via the vena cava to the heart, and from there through the lungs. So it's not surprising that the most common site of distant spread of kidney cancer would be the lungs, because that's where these cells would first encounter a filter that would trap them, and not all of the cells there will survive, but cancer cells has the ability to seed in a different organ and grow and survive there, unlike normal cells, which don't travel to a sort of wrong place in the body. So why does this happen? The key of it is in the DNA. Within the cell, there's a cell nucleus, and in the nucleus are the chromosomes, and the chromosomes contain our genetic code, our DNA that we inherited from our two parents. And the DNA controls all the processes within the body. And in very basic terms, a gene is basically a little bit of DNA that codes for a specific protein. And that specific protein will have a specific job within the cell. Cancer is related to errors or mistakes or injuries or problems with that DNA code. And many cancers are related to genes that control processes of cell division. If we say that cancer is uncontrolled cell growth, you can see that if you have within the DNA, there are genes that control, that suppress uninhibited cell division. There are other genes that promote cell division. And if you have an underexpression or a blockage or a problem with a suppressor gene, you can have uncontrolled cell growth. And also if you have overexpression of a gene that promote cell division, you can have uncontrolled cell growth. Now why does this happen to the DNA? Some of it might be inherited, and some of it might be acquired, and some of it might be just bad luck. Most cancers are in fact not lifestyle or genetic related, but is bad luck. Errors happen in the DNA all the time, but they get repaired. The cell has mechanisms of repairing those errors. If you have a certain set of circumstances with certain errors in the DNA, that would give you the propensity to have a certain cancer. If you inherit some of those already, then it only takes a few of the unlucky or environment-related errors to perhaps get to a situation where a cell might become cancerous. That's an oversimplified explanation, but in broad terms, the key to all of this is in the DNA. So what about kidney cancer then? There's lots of different types of kidney cancer, but overall, it's not as common as breast cancer or prostate cancer or lung cancer, colon cancer, which would be in the top for you, but it's not that rare either. It's perhaps about 10th or 11th in terms of incidence. It's 4% of all adult malignancies, 10,000 cases in the UK per year, just over that now. Quite a lot of people dying from kidney cancer. Over 4,000 people died from kidney cancer in 2012. For reasons that we don't really fully understand, it appears to be increasing by about 2% per year. It's more common in males than females. It's more common in the latter part of life, and in some people it can be in both kidneys. Most kidney cancers start in this, what's called the proximal convoluted tubule, which is a specific part of the nephron, the bit of the kidney that drains the urine. Within the kidney itself, what we call renal carcinoma, which will be most of this, starts in the which we call the parenchyma, which is the meat of the kidney. This here is the plumbing, the drainage bit of the kidney that collects the urine and drains it down to the bladder. This part of the kidney gets a completely different kind of cancer called urothelial or transitional cell carcinoma, which is very similar to, or exactly the same as the cancer you get in the bladder. And that's because the plumbing, the drainage tube of the kidney, is lined by the same cells as the lining of the bladder, which perhaps makes sense. Here you can see increase for men and women. Some of this is probably related to increased detection. So all of us are having more, people are having more scans, ultrasound, CT scans, for a variety of other reasons, and sometimes many more than perhaps 15, 20 years ago. But it is believed that this is actually, at least in part, a real increase and not just an increased detection of what previously would have been undetected disease. A slide showing the higher incidence in the older age groups. Kidney cancer in young people are rare, but not unheard of. So if someone has a mass or a growth in the kidney, like this is normal kidney down here, this is a cancer up here, what could it be? Most are what we call renal cell carcinomas or clear cell carcinomas or hypernephromas in the old terminology. But there are other cancers and other things that can present with a mass in the kidney. Some will be benign. Oncocytoma is a mass that looks just like a cancer on a scan, and it is a mass, it is a tumor, but it's not a tumor, it's not a malignant tumor. It can't spread to other parts of the body, it can't kill the person, it can destroy some of the kidney tissue, it can get quite large, difficult to diagnose beforehand. We often take these out and then only later on the analysis know that it's not actually a cancer. And then there are other rarer cancers. We talked about the cancer of the lining, the urothelial carcinoma, spread from other organs. Larger kidney masses are more likely to be malignant than smaller kidney masses. Not all of the renal carcinoma, so the cancer of the parenchyma, of the meat of the kidney, not all are the same. The most common type is what's called clear cell carcinoma. This has a worse prognosis than papillary carcinoma, which is often familial and often multifocal. Chromophobe carcinoma also has a better prognosis than clear cell carcinoma. These all look different under the microscope. The pathologists do stains on the tissue to tell us exactly what type of cancer we are dealing with. This is fortunately a rare type of kidney cancer that is highly aggressive and unfortunately usually fatal. So why do people get kidney cancer? We We don't know a lot of the time. We know certain risk factors. Smoking, it's not nearly as strong an association as, let's say, lung cancer, but there are clear, proven association with smoking and obesity and people who have been on dialysis for many years. On dialysis, people, that's kidney replacement therapy for people with kidney failure. Patients on dialysis develop cysts in their kidneys, and a specific type of cyst called acquired renal cystic disease. And these patients have a much higher incidence chance of developing kidney cancer. There are several genetic syndromes that have a much increased risk of developing kidney cancer. These are all fairly rare and only constitute 1 to 2 to 3% of all renal malignancies. I'm not going to say too much about the rare syndromes, but von Hippel-Lindau syndrome is interesting in that the deletion, the genetic error is in chromosome 3, in the short arm of chromosome 3, and this gene that is defective is normally a tumor suppressor gene. It's a gene that would suppress cell growth, as I explained right at the beginning. And many of the patients with sporadic kidney cancer, in other words, people who develop kidney cancer for unknown reason, if you look at the genetics in those cancers, you see often in this very same gene, you see problems in that same area. Patients with this syndrome have a 35% chance of developing kidney cancer in their lifetime. Tuberous sclerosis is another autosomal dominant genetic disorder. In other words, if one of the parents has this gene, then there is a high chance of inheriting. You only need one gene from one of your parents to have this disease. But here the chances of kidney cancer is 2%, much less. So how would you know if you have kidney cancer? One of the problems with kidney cancer is you probably won't know. Most kidney cancers, especially early, and early can be for many years, give no symptoms whatsoever. So a small mass in the kidney, the likelihood is that you would not have any clue that it's there. About 10% of people present with what used to be called the classic triad of pain, blood in the urine, and a mass palpable in the flank. But that is when kidney cancer has become very large. Early on, you would not have blood in the urine, and you would not have a palpable mass. Many people present with non-specific symptoms, with weight loss, change in bowel habit, feeling generally unwell, fever, night sweats. Kidney cancer can produce a whole host of hormones and chemicals that can make people feel ill and can cause what's called paraneoplastic syndromes, which are clinical syndromes related to substances produced by the cancer rather than the actual physical infiltration of organs. And these can be abnormal serum calcium levels, high blood pressure, high white cell count, etc. Many patients are diagnosed what we call as an incidental finding. The patient had a scan for something else, and this detects a mass in the kidney. If we get referred somebody with suspected kidney cancer, we do a range of tests. There is no blood test that can prove or disprove whether you have kidney cancer or not. The purpose of the blood test is to check your blood count, kidney function, etc. The main way of diagnosing this disease is by imaging. Ultrasound will detect most kidney masses and kidney tumors, but the mainstay of investigation really is a CT scan together with an injection of intravenous contrast. And here is a CT scan picture. That is a normal kidney on this patient's right-hand side. That's the liver up there. This is a normal lower pole of the left kidney, and all of this is a big kidney tumor, a big mass. What we want to know from the CT scan is the position of the tumor, the size. We want to know the extent. We want to know if it is spread anywhere else. And we want to know if there is a kidney on the other side. Not everybody has two kidneys. And if the other kidney is normal or not. The places that kidney cancer spread to. The places we specifically look for are the lungs, the lymph glands, near the kidney, the structures around the kidney like the adrenal gland. In this case, the spleen up there is closely adherent to this tumor. We seldom do a biopsy. We sometimes biopsy small renal masses where we're perhaps considering not doing any treatment, but for a large renal mass, for the majority of renal masses, we make our decision regarding treatment based on the pictures. We use a standard staging system, and this is called the TNM system. I'll move on.